So I'm going to be talking about myositis specific antibodies. And the goals for this session are to review what myositis specific antibodies are, review the meaning of the myositis specific antibodies in juvenile myositis, and review how myositis specific antibodies are tested. So just briefly, juvenile dermatomyositis is an inflammation of muscle and skin, and juvenile myositis in general is similar, just doesn't have the other skin component, but generally is thought to be due to overactivation or dysregulation of the immune system. And there's a wide variation in the features and severity of the disease, even though it's all under the umbrella of juvenile dermatomyositis or for the other types of juvenile myositis under that umbrella. So there is still a need to further define subgroups within JDM with the overall goal of really trying to personalize what to expect for a particular person or what treatments might be best for a particular person with juvenile myositis. So this brings in the idea of biomarkers. Biomarker is a very general term, for which I included the definition here. As a reminder, it's any sort of biologic marker that influences or predicts the incidence or outcome of a disease. So it could be just something that helps us with diagnosis of JM or tell us about what sort of features might be associated with JM or what to expect in long term. So it's a very broad definition, but myositis-specific antibodies falls into the category of biomarker. So I was going to review a little bit about the immune system in general. So we mentioned the immune system. The immune system for all of us as humans helps protect us from outside invaders to the body. Most commonly infections. There are a lot of different types of infection, and it also is helping to protect us from development of cancer. And we're all familiar with blood draws in blood. There are a lot of different components in blood, and white blood cells are actually a small component of what's in the blood, but that's where most of the immune system components are. And there are different parts of the immune system. There's an innate immune system, and most of those cells are rapid reactors to outside invaders to the body. They act within like seconds to days, whereas there's also an adaptive immune system, which is more specific and takes more like days to weeks to react to specific invaders or foreign things in the body. And that adaptive immune system includes cells called B cells, which produce antibodies. So that's connecting back to this myositis-specific antibody topic. So what is an antibody? So the B cells, which are part of the immune system, they make antibodies, which are these Y-shaped things that are shown in this picture, and they're also called immunoglobulins. So you may have heard of that as part of IVIG or intravenous immunoglobulin, which is also used as a treatment. In general, antibodies are kind of soldiers in the immune system, and they attack or block specific components of proteins or pathogens that are found within the body or in the circulation. So those things that they attach to are called antigens, and most commonly this is thought of in the context of infections. And normally for the immune system, it's a complex balance of trying the immune system constantly checking what's in the body. Should this be here? Is this something I should attack, or is this something I should maintain and leave alone? So it's a constant balance of the immune system checking, is this something that's part of me, part of the self, or is it something foreign and I should attack it? So what is an autoantibody? So auto in this context means self. So an autoantibody is when an antibody is mistakenly attaching or attacking something that's normally occurring in the body. So it's like an antibody that's something in self. And it's not 100% clear why this happens. It's thought to be some combination of genetics. There might be genetics to contribute to how the immune system develops in an individual or in a family, and environmental factors are thought to contribute. For example, in the setting of an infection, the immune system may be already overly active with a true infection, but because it's overly activated, it may also start recognizing self things as things to attack as well. But in general, this autoantibody, an antibody that recognizing something that's normally in your body or normally part of yourself, having that is a key feature of this category of autoimmune conditions, of which juvenile myositis is one. So the most common autoantibody in general is the antinuclear antibody, or ANA. And the ANA is when there's an antibody to really, it's kind of nonspecific to anything that can be found in the nucleus, the center part of the cell. But there are specific autoantibodies that have been described in other conditions. For example, there's double-stranded DNA that's been described in lupus, and anti-neutrophil cytoplasmic antibodies, or ANCA antibodies, in vasculitis. So there's a precedent for finding these very specific autoantibodies for specific conditions. So what about myositis-specific autoantibodies? So myositis-specific autoantibodies, or MSAs, are supposed to be more specific to juvenile myositis. So that's why they have that name. And they've been seen in up to 60 to 80% of juvenile myositis patients. And generally, each patient should only have one of these myositis-specific antibodies, though they can have other autoantibodies. Like you may also have a positive antinuclear antibody, and there are other myositis-associated antibodies or other types of antibodies that are not so specific, which someone can also have. And in general, these antibodies, these myositis-specific antibodies, are not to be like the immediate cause of a disease. So it's not like thought to be, if you find that, oh, then we know that this is what caused juvenile myositis for someone, but it's thought to be a biomarker, like we've described. It's something that can be associated with helping with diagnosis or predicting what could be the outcome with the disease. So why are these important in juvenile myositis? So in general, with diagnosis, for example, juvenile myositis generally can be diagnosed by a pediatric rheumatologist based on clinical features like a history, a detailed review with the family and the patient, the child, of what's been happening and how that evolved over time, and a detailed physical examination, like assessing strength and specific rashes and any other features. There are standard laboratory studies that can be done in any lab, like checking for muscle enzymes and blood counts. And this may also include imaging, like by MRI, and may or may not include getting a muscle biopsy. But there still is a lot of variation in juvenile myositis. There are many juvenile myositis patients that haven't read the textbooks and don't follow exactly what's classically seen. So sometimes in those cases, myositis-specific antibodies can be helpful even in diagnosis. But in general, the myositis-specific autoantibodies, even if they're not necessary for diagnosis, they can help define subgroups within the large umbrella of juvenile myositis that have more consistent features within that subgroup, though it's not 100%, like not everyone with the same MSA group will have the exact same features. And again, it's still considered to be a biomarker that may help with diagnosis and may help with prediction of certain features and how the course of the disease may go. Yeah, so they can particularly help if the presentation is not typical, and then help learn about how to predict somewhat what features may evolve over time and how the outcome or prognosis of the disease may be. And in general, we're hoping that MSA can be part of an overall portfolio of what can help us personalize medicine in juvenile myositis. All right, so next we'll go through some specific examples of the MSAs. So anti-TIF1, which has also been called P155-140, is the most frequent MSA in juvenile myositis. And if it had one characteristic, it would be that it was more associated with skin disease. So it's present in 22 to 32% of juvenile myositis based on different studies. Most associated with juvenile dermatomyositis, so with the skin features. It's a little bit less common among adult myositis, just for context, and it is particularly associated with cancer-associated dermatomyositis, which we heard some about from Dr. Tansley from this morning, but that this malignancy association is not true in kids. And in general, this TIF1 juvenile dermatomyositis, they tend to have moderate to severe weakness and a lot of photosensitive rashes, which means rashes that are correlated with sun exposure or UV light exposure. So that includes the V sign, which is like the V area right here around the neck, shawl sign, which is around the shoulders, a malar rash or like a butterfly rash across the cheeks and the bridge of the nose, and linear extensor erythema, which is a reddish rash along, like instead of where you flex your elbows, the outside, so the extensor areas of the arms and other extremities, and a rash on the scalp. Erythroderma, a generalized red rash, can be seen with this antibody. Edema, or like a generalized swelling, and generalized lipodystrophy, or a loss of fat tissue, has been associated with this antibody. But again, all of these features are just features that have been seen to be more associated with those juvenile myositis patients that have this antibody, and it's not 100%. And in general, this antibody is associated with a more chronic illness course, so it's expected to, for individuals with this type of antibody, may have their active disease for longer and may need treatment for longer. So that might indicate in general, like if we knew someone had this MSA group, we'd be more aggressive in photoprotective or skin protection measures and maybe be more aggressive or more prolonged with how long someone would be on therapy. The next most common antibody in juvenile myositis is anti-MJ, also known as anti-NXP2. So this in general is associated with more severe weakness and calcinosis. But again, these are associations and not 100%. So this is present in 12 to 23% of juvenile dermatomyositis, and it is occasionally associated with some of the other types of juvenile myositis, like juvenile polymyositis, which doesn't have the skin rash features, and juvenile connective tissue disease, which is when juvenile myositis overlaps with other connective tissue diseases. It is also seen in some adults, 2 to 30% of adult dermatomyositis and 8% of adult polymyositis. There is some malignancy association with adult dermatomyositis patients who have this antibody, but that's not true in kids. So as far as the clinical features that you would see with this antibody in juvenile myositis, they tend to have more muscle cramps. So a lot of times with juvenile myositis, they may have weakness, but not associated with any pain. But with this antibody type, there's more likely to be a muscle pain associated. Muscle atrophy, which is a wasting away of the muscle tissue. Joint contractures, where there's a loss of range of motion at the joints, where it gets kind of stuck and you're not able to fully flex or extend. You tend to be, in general, weaker and have decreased function versus other people with juvenile myositis with other antibodies, and have more inflammation on the muscle biopsy. It has been associated somewhat with malar rash, which is that butterfly area rash across the cheeks and bridge of the nose. Gauthron's papules, which is a scaly red rash seen on knuckles, elbows, and knees. So this is seen in juvenile dermatomyositis pretty broadly. It is less associated with having any rash on the body trunk. And then there is this increased association with calcinosis, 43 to 54% in UK cohorts has been described. There's more association with dysphonia or having a change in voice, and gastrointestinal ulcer. That's not common in overall. It seems to be more associated with this antibody than other antibody groups. And as far as the outcome overall with this antibody, there's a decreased chance of having remission by 2 years and an increased association with hospitalization. So in general, it does seem to be a more refractory and severe course with this antibody group. But again, nothing is 100%. And then the third most common antibody or MSA group is anti-MDA5. So this, in general, is more associated with lung disease, arthritis, skin ulcers, and actually less associated with myositis. It was initially reported more in adult dermatomyositis, with 7 to 13% of those individuals having this antibody group, and then described in Japanese juvenile dermatomyositis to be actually very common in 32% of their juvenile myositis patients, and then described to be in 7% of a UK cohort of juvenile myositis. So in the Japanese juvenile dermatomyositis cohort, they had a pretty high incidence of rapidly progressive interstitial lung disease that can be abbreviated with RP-ILD, which was even life-threatening in some of those individuals. About a third, or 35%, had chronic interstitial lung disease, and they tended to not have this elevation of the muscle enzyme CK or creatine kinase, and just in general have less obvious muscle disease or weakness. And for some, there was from the physician or clinician who evaluated them, really no obvious muscle disease, but they did have more skin ulcers, which you can see in the pictures. So in this type of category or presentation, having the antibody might be helpful because the person initially evaluating might only know about the interstitial lung disease, and without the muscle disease and without knowing this antibody, might not even know that this would fall under the umbrella of juvenile myositis. In the UK cohort in which this antibody was less common, they also saw more skin ulcers and some increased association with oral ulcers, or ulcers in the mouth, and arthritis, very commonly, 86%. They also saw more common interstitial lung disease, but they didn't see this very severe and rapidly progressive type. They also saw that there was less or milder muscle disease. And overall, they found outcome was that they often were inactive by 2 years of age, after 2 years of diagnosis, sorry. And then I was going to briefly mention some of the other less common MSA groups in juvenile myositis. Anti-MI2 or Me2 is in 2 to 13% of juvenile myositis. They tend to have classic rashes, or kind of have a more classic presentation of juvenile dermatomyositis, and actually tend to have a good response to therapy. Anti-synthetase antibody is actually a group of antibodies, most commonly anti-Jo1 that's been described more in adults. This category of antibody is actually the most common antibody in adult myositis, 20 to 25% of adult myositis, but it is much less common in kids. This antibody group is associated with having more arthritis or joint inflammation. They have a distinct hand rash called mechanic's hands, where there's a roughness on the sides of the fingers, and they tend to have more lung disease, which can sometimes be life-threatening. And then anti-SRP is not very common, about 1%, but this is considered a necrotizing myopathy associated with having a very high CK muscle enzyme and significant weakness. And if muscle biopsy is done, it shows this necrosis or cell death, which goes along with this name of necrotizing myopathy. So sometimes it can be more difficult to treat. And as we heard from Dr. Tansley, there are, if you've been keeping track of the numbers, a large number still that are MSA negative, 28 to 57%, but this may go down as the testing improves. I was going to mention this other antibody that has been more recently described, first described in adults. It's called anti-HMG-CoA reductase, or anti-HMG-CR. In general, this is associated with more severe muscle disease, and it's considered a necrotizing myopathy like the anti-SRP. So this has been described in 6 to 22% of adults with this idiopathic immune-mediated myopathy, with muscle fiber death and necrosis on biopsy, but not a lot of inflammation actually on biopsy, and then it's not typically associated with the characteristic dermatomyositis rashes. You may know that statins, the medication, lipid-lowering medication, the way it works is to inhibit the HMG-CR enzyme. And they actually found in adults that 2/3 of them that had this type of myositis had previously been exposed to statins, so there may be some association there. But in these adults, 80% were greater than 50 years of age, and they had symptoms that persisted and progressed even after they came off of the statins for those who were previously on them. Since we learned that this antibody existed, we've checked for this in juvenile myositis and found that it was present in about 1% of juvenile myositis. Statins are not commonly used in pediatrics, so it's not really associated with that statin type of exposure. But it is associated with myalgias or muscle pain and having severe weakness. And notably with juvenile myositis or myositis in general, it tends to be more proximal, like in the muscles that are closer to the core, like thighs close to the hips and like your neck and your shoulders close to your core body. But with this type of antibody group, you would also see distal weakness, which means involving muscles that are further away from the core. Very high muscle enzymes, wasting away of muscles or muscle atrophy, joint contractures where the joints kind of get stuck and you can't fully flex or extend the joints, and arthralgias or joint pain. And similar to in adults, you would see muscle fiber necrosis or muscle fiber death on biopsy, and that it may be kind of refractory to medications and would follow a chronic illness course. So how is this MSA testing done? So I'm not personally an expert, but we did hear some about this from Dr. Tansley, and I'll just review a little bit, and we can ask more questions if we have them. But in general, for any type of testing, including biomarker testing, we want something that's very reliable, like every time you test the same sample, you get the same result. You want it to be sensitive, to be able to pick things up even if they're at low levels, specific, like it will differentiate your antibody from other antibody types and be validated. Like if someone else did the same type of, wanted to check that test with a different methodology, they would get the same result. And so that we've heard about there are many different ways to do this type of antibody testing. I just included a graphic of like an example of one type called an ELISA. So if we knew the antigen or protein that we wanted to check for an antibody against, in this graphic, the antigen is like attached to the surface. And if we added some of somebody's serum, like a patient's serum, we wanted to check, do you have an antibody to this antigen? So we'd have, for example, the TIF1 antigen attached. We'd add some of your patient's serum and see if they have an antibody that attaches. We'd add a secondary antibody to check for that antibody, and then we'd have a way to try and visualize if that antibody was there. So there are a lot of different ways to do this type of antibody testing, and there's a lot of specifics that we don't need to get into, but they vary by how sensitive they are, how specific they are. Sensitive means like, are they able to detect it even if it's at lower levels, or is it going to miss some that are not, even though they are there, will it say that it's negative? Specificity means that refers to like how accurate it will be. And we heard about how with immunoprecipitation, for example, it can be very labor intensive because it's very specific and sensitive, but maybe it will be costs a lot in time and in money because it requires a lot of expertise. So we have to weigh that as far as if that's the best test. And then the different types of methodologies differ in how many of these types of different antigens or how many different MSA groups they can test at once and what types of antigens they can test for. So there actually are a lot of different labs performing this type of testing, Myositis Specific Antibody testing, but they're not all created equal because they use different types of methodologies. And actually the 3 most common antibodies in juvenile myositis, the TIF1 or P155-140, and XP2 or MJ and MDA5, at least in some things that I've read, seem to be the most sensitive and specific and reliable by using a combination of immunoprecipitation with immunoblotting. Because it's possible with other methodologies, they may have lower specificity and sensitivity, and there are not very many labs that use this methodology. So in my experience, though, you can do like Myositis Specific Antibody testing, that get that type of testing done through many labs. The only laboratory that in the US that uses that combination of immunoprecipitation with immunoblotting is this Oklahoma Medical Research Foundation. And actually they have two different types of myositis antibodies that are listed. And of those, you have to make sure the right one is ordered. This comprehensive myositis autoantibody profile, particularly in pediatrics or in juvenile myositis, because that is the one that includes the most common ones in juvenile myositis. Whereas this traditional myositis autoantibody profile above actually includes more of the antibodies that are more common in adults. And it does take 6 to 8 weeks to get results. And as far as the anti-HMGCR testing, this is newer testing that's been developed. And to my knowledge, there's only one test laboratory doing this testing reliably, this RDL lab, which is different from the OMRF lab that does all of the other types of testing. So as a summary, myositis-specific antibodies are a biomarker found in the blood. And we think that they are useful because they can help define subgroups in juvenile myositis and can provide some information about what to expect as far as clinical features and the clinical course, and sometimes may even be helpful with diagnosis if someone has an atypical presentation. And the three most common myositis-specific antibody groups in juvenile myositis are anti-TIF1 or P150-5-140, anti-NXP2 or anti-MJ, and the anti-MDA5 groups. And overall, we're hopeful that this will help us better personalize medicine. And there's been a lot of ongoing research to help us better understand what these antibodies mean for different people with juvenile myositis. And we think it's important to continue to do this, even though it may not necessarily be required for diagnosis, by studying it more and putting it in the context of other biomarkers and other features. Together, we're hoping that it will help personalize medicine to be able to determine the best treatment for an individual and what to expect for an individual. And then I just included again that at least currently, the most reliable and validated place to do the MSA testing for most of the antibodies is through this center, and for this particular other anti-HMGCR antibody, it's through this other lab. But we'll learn more from Dr. Tansley's research as well about if there's other simpler testing that may be just as reliable, but that's pending. Well, that's all I had. So we're open to taking any questions.
So we had the traditional antibody test done, and it showed a weak band of potential anti-MJ. They said it's difficult to tell on the traditional, and we would have to do the blot test to see if it was in it. Do you recommend going ahead and getting the more specific antibody test done if they see a weak band there that indicates the possible presence of MJ?
So MJ would produce what we call a 140 kilodalton band, yeah. On immunoprecipitation, they're usually weak bands, so MJ and MDA5, that 140 band is often a bit difficult to see. So if they're doing it how we would do it in our UK lab, we're looking, at a kind of piece of film for a black line. Sometimes it's quite difficult to see and to tell if there really is something there. And we would also go on to do other tests. The other thing is that you couldn't tell from the band alone whether you've got MJ or MDA5. They are at slightly different heights, but the difference between them, I don't think you could reliably tell by eye. So you do need to go on and do some other form of testing, like the immunoprecipitation blotting, Maybe there are other simpler tests that you could do, but I think if you want to know whether it's definitely MJ, you need to do another test, yeah.
Is there a way that the doctor would say that they have MDA5 even before? I mean, we were told like 4 weeks after diagnosis that she has MDA5, but there was a lot going on, so I don't know even what kind of testing she got. But now she's doing like annual lung function tests, but she hasn't shown any signs of that. So I guess I'm just asking from like what kind of testing would have come back that soon?
So some forms of testing, like the line blots and things that we've looked into, they can be done in a morning. Okay. So, there's a huge difference in time frame between some of these more newer tests and, the traditional tests like the immunoprecipitation. So if they are effective, there is a benefit in doing tests like that. We're just not sure how reliable they are.
Yeah, I think we've heard about, if it makes sense, there are some MDA5 features that are really more specific to that subgroup of juvenile myositis, and if it makes sense, probably people wouldn't question it. Yeah. But there are tests that are done faster and probably more economical and make sense in a lot of cases, but they may have false positives and false negatives.
Yeah, so whenever we do these tests, we've got to look at them in the clinical context with the clinical picture, and we know what kind of clinical features are associated with these autoantibody groups. So if we do a test that comes back with, say, MDA5, and the patient has clinical features that would fit with anti-MDA5, then that, we can feel confident that actually that's probably a real result. The problem is when it doesn't fit, that we might need to scratch our heads a bit.
So we had the panel done 5 years ago when my son was first diagnosed, and the RO and P155, P55, 140 came back inconclusive. So we had it redone, and I was actually looking up the information. I want to say the second time around, it was inconclusive again for P55, 140. What is that? What do I take from that?
Do you know what type of test was done?
It was the comprehensive myositis.
The one
and it was sent to Oklahoma both times.
So I think they do the immunoprecipitation and then what's called an immunoprecipitation blot. It's not the lab that I work in, so I don't know exactly how they do it, but it might just be that the band was faint. So with all of these tests, you're looking for whether there's something there, and maybe there's something there faintly, and somebody's not 100% sure whether that's real or not.
So just keep doing it?
Well, not necessarily. I mean, I suppose you've got to think about how it's going to change the clinical picture. It might never change.
Yeah.
There are different reasons, I suppose, why you might say inconclusive. Maybe there were bands that weren't there on the immunoblot. It's difficult to say without knowing more information. But that's the problem, that there is no perfect test. Mm-hmm. And even the immunoprecipitation that we think of as the gold standard isn't going to give you a perfect result 100% of the time.
Are you hoping for everything? Should I be hoping for everything to come back negative?
Well, not necessarily.
Okay.
Because, we know that we won't find an autoantibody with immunoprecipitation maybe in about 40% of children, but they're not all the same. There are probably autoantibodies that we just don't know about yet, or we can't detect that within the group. And those children who are autoantibody negative aren't all the same. We know some of those children have severe disease, some of those children have mild disease. So it just means that we can't give you any more information. It doesn't mean that it's better or worse.
Okay.
When my son was first diagnosed, they did the autobody test in the facility at our hospital. And when I asked about the Oklahoma one, my doctor said that he's doing so well that it would just be kind of like a waste of money to do it. Is that an accurate outlook, or should I push to get that comprehensive panel done?
I think, like was said earlier, that the autoantibodies aren't 100%, and you've got to think about how that would change what you do. And, they're a biomarker. They tell us something about the clinical picture, but we can't ignore all of the other biomarkers, if you like, that are in front of us. So somebody's on treatment and they're getting better. That's really powerful, that somebody's going to do well. The fact that somebody's rash has got away or they're getting stronger, they're really good signs. And I think even if you did a test that showed that somebody had an antibody that was associated with severe disease, clinically that wouldn't undo the fact that they were doing really well.
Right.
So I think if somebody's doing well at the moment, it's not necessarily going to change. Would you agree?
Yeah, I agree. I guess it might just be, it's always up to you if you want that information, because it may provide, a hint at what maybe to expect. Like sometimes certain antibodies might be more associated with a flare or up and down course. But really, if someone's doing well, it may not be, it's certainly not urgent. I would agree with that. And unfortunately, it is difficult because even though, like, from an expert and medical perspective, our opinion is that this is the most reliable and best testing, it may not be covered by your insurance. So that's a cost.
Yeah.
So my daughter's positive or negative, I don't know, has that one. Are they sure that there's no cancer connection, or is it something that, as an adult, that she should be screened more for certain types?
So we know that, we've known for a long time that dermatomyositis in adult patients, there's a link to cancer. So before we knew about autoantibodies, we knew that adult patients who had dermatomyositis were more likely to have an associated cancer, whereas that wasn't the case in children. And as we've learned about the different autoantibodies, it's become apparent that that link with cancer is in certain autoantibody groups. We know that the link with cancer, and there's actually a very recent paper published on that, seems to be this is in adults, within the first few years of diagnosis. So adults with anti-TIF1 gamma don't have an increased risk of malignancy forever. It tends to be within the first 3 years before and after they're diagnosed with myositis. And the other thing is, we think of adults and children as different, but there isn't anything magic that happens on your 18th or your 16th birthday. And even within adults, that risk of cancer seems to be in patients who are over 40. So if I had an adult in their 20s with TIF1 gamma, I wouldn't be as worried about cancer as I would be in someone who's in their 80s. So I think, nobody's got a crystal ball,
Right.
But for your daughter's case, it wouldn't be something I think we need to be concerned about.
I just worry about when she's a 40-year-old with the same, you know what I
Yeah,
mean? Like,
yeah.
one day she'll be an adult with the same problem.
So there's no evidence to suggest that.
JM is different, or juvenile dermatomyositis is different than adult dermatomyositis.
Yeah, well, we would love to understand why these autoantibodies are the same in adults and children, and some of the adults get cancer and some of the children wouldn't. That would be, it's really fascinating. And,
Right.
The immune system is a really complicated thing. Yeah.
Would hormones and puberty and that process have anything to do with or account for the difference? That might be a dumb question, but...
Well, we know that the different autoantibodies, the frequency of the autoantibodies is different in adults and children. But again, that difference doesn't happen like a switch at 18. So, sort of older children and teenagers have a different kind of autoantibody profile, if you like, to younger children, and probably older adults have a different autoantibody profile to younger adults. So some of the autoantibodies that we see in adults, when we do see them in children, they're often in older children rather than the very young children. So, it's a continuum that changes, and maybe hormones and things do have a role to play. We know all of these diseases are more common in women. Women's immune system is different to men's on some levels, yeah.
So you're saying essentially, since they have JDM, even when they become an adult, it's still going to be considered JDM? So it won't the J won't drop off. Okay.
Do you have a sense of the percentage of pediatric rheumatologists that just go to this, order this, know to do this even?
My impression is that because it's not really required for diagnosis most of the time, it's not very commonly done. It's probably more often used if there's like an atypical presentation, like like someone that's an MDA5 type of picture where they don't have very obvious myositis or they don't have the classic rashes, it might be used in that case. But either way, the results take a long time, so it's not something that's usually urgently done very often. So it is something which I think the experts in the community, like Dr. Reed, Dr. Pockman, Dr. Ryder, are more and more learning that I think will help us get to the point where we all want to get to, where we can tell you more about what to expect and like what treatments may work best for you. But it's going to require something of a culture change.
Is it sort of like published in sort of like standards of care, like as an option, or is it?
I don't know that it's specifically published in that way. And I think Dr. Tansley had mentioned that we probably will need some guidelines after we find out from her about which tests might work for which things. Like, we may not need this very specific and detailed and prolonged and maybe a bit expensive immunoprecipitation, immunoblotting procedure for all of these antibodies. It may just be only some of them.
I think that one of the things that would enable that cultural shift for us to test these more commonly is if we did have better, faster tests. So, perhaps part of the resistance for testing these is, you don't necessarily need them for a diagnosis. It's going to be many weeks before you get a result, and you want to start treatment before that. But if we can show that some of the faster, tests work well in certain circumstances, or we can at least, have some kind of guidelines of which tests we should be using when, they'll be, a lot cheaper, a lot more accessible, and I think that will really help them be more widely used. We just have to be careful that we know what we're doing when we're using them.
I feel like for me as a parent, it was very informative after the results were in and we were able to sit down and talk about it, because one of the pieces of the information that you put up there about the particular autoantibody that my daughter has, she's at a higher risk for having calcinosis, but that is not it's not an early presentation of the disease. That happens later. Mm-hmm. And so being a newly diagnosed family, that was great to hear that there's something else that could happen, and we need to be on the lookout for that. And, while that may have been part of the discussion just in general, because now I know that my daughter is at a higher risk, I know to be a little more vigilant for that particular piece so that we can hopefully catch it early. Not that it's really going to do a whole lot because there's not really any treatment that's going to prevent it at this point. But I just think that for me as a parent, that little nugget of information was helpful so that now I know what could be on the horizon.
And that's why we want to understand how well these tests work so we can know whether they're going to miss things. And what we might end up suggesting is that we do some of these simpler tests first, but actually in patients who are negative, we do need to have a double checking process, and if we find an antibody and it fits, that's all good. But if we don't find an antibody or it doesn't fit, actually there's another step that we need to take, and we shouldn't just sit back and say that person's antibody negative. But, we've got more work to do to determine that.
I just wanted to briefly mention, it's a very important question you had about the cancer risk. And I wanted to mention it here, even though we are talking about juvenile myositis, but if you happen to read about it, then, or if someone sees a more adult-oriented rheumatologist, they may think about that. But I think juvenile dermatomyositis in general doesn't have the same association with cancer that, even without any of the antibody information, that adult dermatomyositis has. I think in general for autoimmune diseases, not just juvenile myositis, but other things, lupus, juvenile arthritis, both that and the medications that we use to treat those diseases, they probably by themselves indicate versus people who never were on those treatments and people who never had those autoimmune diseases, that there may be a little bit higher risk for cancer. And you may have heard about that because that comes up as a risk factor in a lot of the medications we use. So we think that people who have different immune systems, they probably have a little bit of an increased risk of cancer that we can't really predict, but it's different than the adult dermatomyositis associated risk with cancer. So we wouldn't do any other screening like that they might do for cancer unless there was something else obvious that made us think this person seems like we need to work them up for cancer, which is usually not the case.
everything. RO60, are there typical characteristics of people with that?
I didn't talk about that.
Oh, okay. The only reason why I'm asking is because that was one of the ones that was inconclusive for my son.
So Rho60 is what we call a myositis-associated autoantibody. So it's seen in patients with myositis and other connective tissue diseases, other related diseases. And in general, the associations with the kind of myositis-associated antibodies are less well studied. So I don't think we've got clear information on that at the moment.
Question come over from the live streaming. And that question was, can drug treatment protocol, especially biological medications, i.e. Rituxan or others, affect autoantibody results? For example, my daughter routinely is a P155/140 positive, but tested P155/140 and anti-Rho during severe flare. Has not tested positive for anti-Rho since starting Rituxan.
So anti-Rho, as we said, is a myositis-associated antibody. It can occur in conjunction with other autoantibodies. So while the myositis-specific autoantibodies tend to occur on their own, some of them do occur with anti-Rho. I guess the other thing is I don't think this is something that's been studied, but theoretically, rituximab or Rituxan is a drug that depletes B cells, which are the antibody-producing cells. So I guess theoretically, if your B cells are not there or are less and are not producing antibody, that could affect the antibody result. But I don't see why it would affect one antibody over another.
Okay. Okay, another question coming over the live stream. Since my son has had JDM for 10 years and no remission, now at 18, do you recommend this testing?
I guess this is similar maybe to the other person who asked about it. I mean, there's certainly, like another parent mentioned, like there may always be some benefit to getting more information, but for someone who is in remission and is not like at a treatment decision time point at this right now, it may not be as urgent. And also, maybe unfortunately, we don't really have a lot of information about how these results may change over time and with treatment, kind of alluding to the earlier question and one of the questions you got before. Yeah, so we may not know that like perhaps this individual had an antibody early on in disease when they were active, and we don't know if these results will still be the same when someone's many years into disease and doing well.
So you mentioned that the anti-Rho was associated. Which other ones are also associated with other diseases also?
So there's Rho60 and Rho52. There's two ones that are both myositis associated. Then antibodies like U1-RNP, which we see in myositis and also other diseases like mixed connective tissue disease and lupus. And there are autoantibodies that we see again in overlap diseases, anti-Q, PMSCL. We've got U3-RNP. We've got some patients like that in our cohort.
I wanted to clarify. I think I misheard for the live stream question that I heard that they were in remission, but I think they were maybe not in remission. So
Not.
for someone who's not in remission, it may be helpful, I guess, because we may learn some more information about like what to expect. And it sounds like for someone not in remission after so long, they may want to know more information to help with guiding treatment decisions. So in that case, it may be helpful.
When I was little, I was diagnosed with dermatomyositis at 6, and then now I'm 40 and I still have it. But so I was tested for lupus, whatever it's called. It was negative, and then in February of this year, it came out positive. And then also when I was little, the anti-Jo was positive, and then now it's negative, so I don't have it. So I'm just wondering what your thoughts are on that. I know you might have touched on it, but I just wanted to see if there's any more specificness of those biomarkers.
I think it's always difficult when we're looking at things over a long period of time, and I guess we just, we don't have the data in clinical studies about different autoantibodies being tested over time, and them becoming negative or becoming positive again. Logically, I wouldn't expect somebody's autoantibody profile, the ones that are positive, to change over time. But it might be that an autoantibody could become negative, or it might be in relation to how things were tested, whether, and also, as I spoke about earlier, we do get false positive test results. So just because something's come up positive doesn't necessarily mean that it's there, and if it doesn't fit, we have to question that.